extrapulmonary effects of COVID-19. That is, the effects of COVID on the rest of your body outside the lungs. And we'll be paying particular attention today to the effects of the virus on the heart. The famous disclaimer, once again, the information we're giving today is not definitive, and indeed the finer details of what we discussed last week have revealed themselves to be somewhat more complex than we anticipated. But what hasn't changed is the basic core principles and the confidence that we're hoping to try and instill in you all when dealing with this pandemic. As Blair said, it's a difficult time for charities, and any help for the Devon Air Ambulance Trust would be really appreciated. We're so close to £500, which would be absolutely fantastic. And so the focus of today will be on managing and recognising some of the consequences of COVID on the other parts of the body that we've not yet addressed. And it's worth starting with a quick reminder of how the SARS-CoV-2 virus infects the body. And in order to do that, we need to have a quick chat about the renin-angiotensin system. Now, renin is an enzyme, a protein, that activates angiotensinogen so that it becomes angiotensin 1. And ACE, angiotensin converting enzyme, turns angiotensin 1 into angiotensin 2, which is a vasoconstrictor. It makes your blood vessels squeeze more, which raises your blood pressure. Now, angiotensin converting enzyme 2, ACE2, turns this vasoconstricting angiotensin 2 into angiotensin 1-7, which is a vasodilator. It makes your blood vessels relaxed. And so hopefully you can see that ACE and ACE2 work in opposing directions to try and maintain the balance of blood pressure within your body. And perhaps the most crucial fact is that ACE2 can be found on cell membranes throughout the body. Now, ACE2 is designed to interact with angiotensin 2 as part of the normal physiological process. But SARS-CoV-2 is able to hijack this process through the proteins it expresses, and it can trick ACE2 into allowing entry into the cell. And so where there is ACE2, SARS-CoV-2 can also enter. And ACE2 can be found in the lungs, kidneys, intestines, and importantly, the heart. The heart lining contains ACE2, and so it's reasonable to infer that COVID can affect the heart. And there is indeed a high rate of cardiac injury in COVID patients, especially older patients and those with pre-existing conditions that increase risk of organ damage. I'm talking heart disease, kidney disease, diabetes, and lung conditions. And when I talk about acute cardiac injury, I mean any acute condition that causes the heart to produce elevated levels of troponin. And troponin is a protein that's found in the muscle cells of the heart. And when these cells are damaged, these cells will spill this protein into the bloodstream. And we can measure this rise in troponin as a proxy for cardiac injury. And cardiac injury typically presents with this central crushing chest pain that you find in textbooks that radiates to the jaw, the shoulder, and the left, and indeed frequently the right arm. Although it's important to remember that people with long-standing diabetes may present with what's called silent cardiac injury, or heart attack, or MI. And some studies have shown that women are more likely than men to present with complaints of stomach pain in that epigastric region underneath the chest. Cardiac injury can cause palpitations, or the sensation of being able to feel your heartbeat. And indeed, sometimes it can lead to irregular heartbeats or arrhythmias, like atrial fibrillation, which indeed occurs with many systemic illnesses. If the damage is severe enough, then it may cause ventricular dysfunction, contractile dysfunction, affecting the heart's ability to beat and pump blood around the body. And so this can lead to heart failure, or indeed cardiogenic, that is, originating in the heart, cardiogenic shock. So what signs are there? What tests can we use to check for cardiac injury? Well, as we've said, we can measure troponin levels in the blood. And if the contraction of the heart is impaired, then we can physically see this dynamic impediment through echocardiography, through putting an ultrasound probe over the heart. And very usefully, there will be changes on the ECG trace, the heart tracing. Now, ECG measures the flow of charge, or the direction of flow across the heart. If it's towards the probe, then the line will go up. If the flow is away from the probe, then the line will go down. So when the line is flat, there's no change in the direction or flow of charge. And the heart, for the majority of the contractile cycle, the heart cycle, is stable. And so the line is flat and neutral. And it's really only the P wave, the QRS complex, and the T wave there that deviate from this nice flat line. But when the heart cells are damaged, they'll start spilling all of these charged ions out at inappropriate times. And so you register flow when there shouldn't be. And we interpret this deviation from the baseline as elevation or depression of that ST segment, the section between the end of that downward S deflection and the start of the T wave. And that's why severe ischemia, for example, in heart attacks, myocardial infarctions, that's why severe ischemia can present as ST elevated myocardial infarction, or STEMI, as you might have heard it called. But how does SARS-CoV-2 cause this injury? There appear to be three main mechanisms, the first of which is through direct infiltration. Through using this sneaky ACE2 pathway, these viral fragments, these tiny virus particles, can sneak into heart cells and force them to replicate more viruses until they burst, which of course causes tissue damage. There is of course the chance that the inflammatory immune response to this infiltration can indeed cause damage to the heart itself in a sort of friendly fire mechanism, if you will. This is viral myocarditis, in which the inflammation damages the heart. And we originally thought that viral myocarditis was the main mechanism by which COVID caused heart damage, although it's becoming increasingly clear that myocarditis is actually not as big a player as we thought it was. The second mechanism is through increased demand on the heart. The response to inflammation and low oxygen by the body is to make the heart work even harder to pump the blood around. And this extra strain on the heart may exacerbate underlying heart failure, or it could indeed tip the heart into full-on myocardial infarction or heart attack. Thirdly, there is the chance that COVID could cause damage to the heart through atherosclerotic processes. And atherosclerosis is what we use to describe the buildup of fatty, clotty streaks inside the lining of the blood vessels. And these deposits can either occlude the airway, the bloodstream itself, or it can rupture and send fragments further down the bloodstream to clot and occlude the airway as it becomes the bloodstream, not the airway, as it becomes narrower. And we knew centuries ago that atherosclerosis and inflammation were linked. And it's possible that the inflammatory effects of COVID could precipitate plaque formation or rupture a plaque, leading to occlusion and ischemia, perhaps of the heart. At this point, it's worth remembering that troponin is a measure of cardiac injury, and not just of myocardial infarction, of heart attack. As you can see by the green arrow, MI is just one of lots and lots of things that can cause cardiac injury. And last week we talked a lot about the lungs. We've so far talked a lot about the heart. But as I said at the start, COVID can have lots and lots of targets within the body. And if this is the case, it's worth remembering that these patients may require multiple different interventions in multiple different places. If their kidneys are damaged, they may need to visit the dialysis centre. Or if they've got a heart attack, they may need to visit the cath lab. And it's a logistical nightmare to try and shift all of these infected, infectious patients around the hospital, especially if they're sick. And these patients can indeed get very sick, often due to sepsis. And sepsis is a dangerously overwhelming immune response to infection, which can lead to shock. Shock being hypoperfusion of the tissues, not being able to get all the nutrients and the oxygen to your organs. And as a general rule in shock, we want to treat the mechanism that's caused it. We want to counteract those processes. For example, in cardiogenic shock, for example, originating from myocardial infarction, heart attack, we want to treat the heart and fix the ischemia. In hypovolemic shock, caused by low levels of fluid, perhaps due to hemorrhage, bleeding, we want to treat the shock by giving more blood or fluid. And sepsis causes shock in a few different ways, but two prominent mechanisms are cardiogenic shock. Sepsis can cause the heart to become weakened in its contraction, and sepsis can also cause a distributive type shock in that it weakens the blood vessels, and so they can't squeeze effectively and raise the blood pressure. And so in order to combat these two processes, we can give inotropes, like dobutamine, which will help the heart to contract, and we can give vasopressors, like noradrenaline, which help the vessels to squeeze, thus counteracting the mechanisms by which sepsis causes shock. The World Health Organization is currently advocating that if fluid resuscitation, fluid boluses, aren't raising blood pressure in these patients, then noradrenaline, the vasopressor, is the first line, although these drugs are very rarely seen outside of ICU. There is emerging evidence that COVID does very peculiar things to your blood in terms of its clotting. And COVID patients seem to, on average, have higher levels of D-dimer. That's a factor in your blood that indicates clotting and inflammation than we expected. And nobody's sure why, but patients with COVID seem to be at higher risk of developing blood clots, and indeed throwing off emboli, into the heart, lungs, or kidneys. And the development of blood clotting disorders, called coagulopathies, is highly indicative of poorer outcomes in these patients. And indeed, if a patient becomes septic, they can develop a condition called DIC. That's disseminated intravascular coagulation, in which all of the clotting factors in the blood are used up very quickly, leaving the rest of the blood without any. And so you end up with this rather paradoxical picture in which parts of your blood can be clotting inappropriately and other parts of your blood can be too thin, causing you to bleed. The International Society on Thrombosis and Hemostasis is currently arguing that we should give patients with a raised D-dimer who test positive for COVID low molecular weight heparin, which is an anticoagulant. And it also has the added side effect of being an anti-inflammatory. But in general, the current guidance is that patients with a raised D-dimer who also test positive for COVID should be admitted. and these patients, upon being admitted, should be anticoagulated. Onto the kidneys. And there is emerging evidence in the literature that COVID can cause kidney damage. And kidney damage can present in different ways, and there are clues that we can use to indicate that it's happening. Now, the function of the kidneys is to produce urine by filtering out waste products in your blood, while also maintaining levels of useful substances within your bloodstream. And so if the kidney is injured, this function will be impaired. And so you can end up with raised levels of waste products in your blood, like urea and creatinine, and raised levels of useful products in your urine, like protein. And there will also be resulting imbalance in your useful electrolytes, like sodium and potassium. And of course, if your urine levels drop, that is indicative that your kidneys aren't functioning as well as they should be. The first mechanism by which COVID can cause damage to the kidneys is by capitalizing on pre-existing pathology. For example, patients with pre-existing conditions like chronic kidney disease or diabetes may have lower levels of physiological reserve and so may be more vulnerable to infection. Patients who've had transplants may be taking immunosuppressants, and so their immune system may not be well equipped to deal with COVID infection. A second mechanism by which COVID can cause kidney damage is directly through direct infiltration of those cells, through the production of blood vessels, the production of blood clots, and also through making the body overreact to the infection through the creation of a cytokine storm, in which the body overreacts to the virus and releases lots of inflammatory chemicals that will end up damaging its own organs. A developing field is the study of organ crosstalk, specifically between the lung and the heart and the kidneys. And this is the idea that although the mechanisms are not yet clear, disorders that affect the lungs also seem to be able to affect the kidneys and vice versa. This could be due to acid-base balance processes or blood gas-related processes, but it is indeed a common finding that, for example, in patients with COPD, there is also a coexisting renal impairment. The third and final mechanism by which COVID can lead to kidney injury is by iatrogenic effects. That is, the effect of us trying to treat the condition, which have unwanted consequences on the kidneys. For example, trying to run a patient dry if they have acute respiratory distress syndrome, or trying to pump a patient full of fluid if they have sepsis can cause kidney damage. The medicines, for example, painkillers that we give can, under the right circumstances, be damaging to the kidneys, can be nephrotoxic. And finally, just as Ed said yesterday, a stay in ICU, and indeed in hospital in general, can be hugely stressful to the body. And these kidneys are particularly sensitive to any stress. And the longer you stay in hospital, after all, the greater your chances are of contracting a second infection superimposed on your condition that will start the cycle all over again. Outside the kidneys, there is once again emerging evidence that SARS-CoV-2 can affect the gastrointestinal tract. And this makes sense since the intestines do express that all-important ACE2 enzyme on the cellular membrane. And these patients can present with nausea, vomiting, even bleeding, and loss of appetite. Although this loss of appetite may in fact be caused by the loss of sense of taste and smell that has been linked with SARS-CoV-2's effect on the nerves that conduct these senses. Diarrhea is the most common gastrointestinal symptom with which COVID presents. And there have indeed been cases where we've found viral proteins or fragments of the SARS-CoV-2 virus in stool samples. However, it is as yet unclear whether or not this means that the virus can be spread through feces. Whatever the case is, it's always justifiable to practice good hygiene through hand washing and the use of personal protective equipment. A final comment is the reminder that, if anything, we should be taking away the idea that COVID can manifest in surprising, varied ways. And so it would be foolhardy to dismiss appropriate protective precautions with any presenting patient you encounter. And indeed, the physiological upset caused by COVID in any way could bring about delirium, which is an acute confusional state. And this is especially the case in vulnerable patients, such as older populations. And so therefore, it's always good medicine, even in patients with perhaps long-standing cognitive impairments like dementia, to screen for any recent escalation of their confusion. However, I'm not trying to say that any patient, and indeed every patient, could have COVID. What I am saying is that we should be keeping our eye out for these slightly more peculiar and slightly more varied ways in which COVID could be sneaking up on our bodies. That's the end of the presentation, and I'll let you read through these summarizing points in your own time. But I'd like to finish with the comment that there is a lot of uncertainty at the moment, and things do indeed keep changing. Between writing this presentation and delivering it, and indeed between delivering it now and its arrival on YouTube tomorrow, the knowledge changes, but generally for the better. And we're making progress every day. Really, the best that we can do is practice the basics safely, well, and with kindness as the guiding principle, just as Pam highlighted yesterday. These are some excellent resources, including the link to the YouTube channel upon which we're placing these videos.